and welcome to today's information call, An Approach to Clinical Practice Variations in Care, the ACS-NSQIP. Today we're going to be looking at an example of a data-driven quality improvement program in surgical care called the National Surgical Quality Improvement Program, offered through the American College of Surgeons. NSQIP, as it's commonly known, is the first validated, risk-adjusted, outcomes-based program to measure and improve the quality of surgical care. As you heard, I'm Stephen Samos, Vice President of Programs here at CFHI, and I'm pleased to be your host for today's call. And today on the line we have more than 80 organizations registered for the call. So we're pleased to also be providing simultaneous interpretation of today's call for our Francophone audience. I'm going to introduce our two speakers, but as I do that, please take a moment to introduce yourselves in the chat box. Just let us know who you are, where you're from, and any questions that you may have for today's speakers as we get the presentations underway. I'd first like to introduce Dr. Timothy Jackson, who's a member of the Division of General Surgery at the University Health Network based at Toronto Western Hospital. He's also an Assistant Professor of Surgery with the Faculty of Medicine at the University of Toronto. Currently, his research interests are in surgical quality improvement and surgical outcomes. In 2010, he completed a Harvard Surgery Fellowship at Massachusetts General Hospital in Boston. His clinical focus is in bariatric and gastrointestinal tract surgery. Also with us today is Lila Gottenbos, who is a surgical clinical reviewer at Langley Memorial Hospital in British Columbia. Lila has been with the NSQIP program since its inception in BC in 2011 at the Langley Memorial Hospital. Prior to becoming a surgical clinical reviewer, she was a registered nurse on an inpatient surgery unit, a perioperative nurse, and a clinical nurse educator. Lila has spent her 14-year career dedicated to improving outcomes for the surgical patients at Langley Memorial Hospital in BC. We also have our producers here in Ottawa, Sheena Powell and Kelly Ripley, operating behind the scenes. In today's session, we're going to start with an introduction to the NSQIP program, what it is, the history behind it, what it encompasses, and how it can help drive quality improvement through the use of data. We'll drill into two case examples, one from BC and one from Ontario, of organizations who are already participating in the program, and learn from them how NSQIP is helping to improve the quality of surgical care across their both organizations. We'll also look at how NSQIP is linked to this quality strategy in Ontario and discuss opportunities in the Canadian context for those interested in learning more about this program and how to get involved. For those of you who are less familiar with CFHI, here, let me just provide a very quick overview of who we are and why we're bringing people together to learn more about this topic today. CFHI is a national Canadian, pan-Canadian organization dedicated to accelerating healthcare improvement for Canadians. We work with governments, policymakers, and health system leaders to convert evidence and innovative practices into actionable policies, programs, tools, and leadership development. Our vision is timely, appropriate, efficient care that improves the health of all Canadians. And how do we do this? We partner with healthcare leaders and we build local capacity to lead improvement. We support the design, implementation, and evaluation of evidence-informed improvement and help others to achieve small-scale change. We provide improvement advice and offer coaching through our own staff and through our network of faculty and coaches, with a goal overall to spread successful improvement across Canadian healthcare. As you can see from our improvement model, this model visualizes our approach to healthcare improvement and has a strong focus on implementation, evaluation, and the spread of improvement. The model articulates our role in supporting improvement initiatives and building capacity through tailored learning, collaboration and networking, improvement advice and coaching, and analysis of evidence. We spread expertise and best practices within and across organizations, regions, provinces, and territories to maximize value for money in healthcare spending, improve patient experience and outcomes, and to provide a more coordinated approach to complex health needs, all to improve the health of Canadians. I just wanted to turn your attention that in the improvement model we do identify 6 action levers that guide organizations toward the changes needed to become more high-performing healthcare organizations. And as you look through these, you can see there are many parallels to be made between those levers that we identify and the work of NSQIP. For example, engaging clinicians and frontline managers in creating an improvement culture. You need to engage the right surgeons, nurses, anesthesiologists and administrators if you want to redesign how surgical processes take place. And in order to get buy-in and support from these key stakeholders, the information you present to them needs to be grounded in evidence. Building organizational capacity to carry out these changes requires creating self-reliance for improvement within your organization, such as skilling up staff in healthcare improvement, giving them the ability to identify necessary improvements based on evidence, and supporting them in implementing these changes. And as our presenters will share today, NSQIP can offer benefit to patients by decreasing complications, supporting providers in creating opportunities to improve care, and to potentially reduce costs. Our presenters today will describe efforts underway in both BC and Ontario in this regard. Dr. Tim Jackson will introduce NSQIP and speak about how it can improve surgical care in Canada. And Lila will discuss the experience of implementing NSQIP in BC. It's now my pleasure to turn the presentation over to Dr. Jackson, who will then turn things over to Lila and then back to Dr. Jackson to close out the presentation. Dr. Jackson, over to you.
Great. Thanks so much, Stephen. I really appreciate the opportunity to be here, and thank you all for being on the call. I'm really excited to just give you guys a broad overview of NSQIP and give you a sense as to what it is. But before I do that, I just want to put a little bit of disclosure out there. So I'm a surgeon working at Toronto Western Hospital, and I've been using NSQIP in our hospital for many years now. I've recently been fortunate enough to work with Health Quality Ontario on a broader provincial initiative, and my bias is that I think this is a really good thing for patients, and it's a really powerful tool to improve care. So you guys get the sense as to where I'm coming from on this right from the beginning. So what I'd like to do just on the first part of the webinar here is just give you an overview of what NSQIP is, look at a few ways it can be used to improve care, and then at the end of the webinar, I'm going to come back on and talk about some opportunities within Ontario in the Canadian context. So to start off, to answer the question, what is NSQIP? Well, it's pretty straightforward. It's a data-driven program designed to measure and improve the quality of surgical care. And it's actually been around for about 25 to 30 years now. It has its origins back in the Veterans Affairs hospitals in the 1980s in the United States, and it really was born out of there. And it's had a long history, and consistently it's been demonstrated to not only improve care by reducing complications, but as a side effect of that, so to speak, decreased healthcare costs, because as we all know, complications are very expensive and high quality care tends to cost less. So just to put things in perspective, there is a map on your slide showing the number of centers that are enrolled in NSQIP as of January 2014 there, but just to give you a broad sense, it's about 5 to 10% of hospitals in North America and approximately 50 or so in Canada now. That slide's a little bit outdated, and there are more now, which we'll talk about in the end of the presentation here. So that's a snapshot of what NSQIP is. Now, what are the key features of it? Well, really, I think the most important component of NSQIP is the data. And NSQIP relies on data to be a quality diagnostic tool. It allows us to give us a good sense of our performance and how we're doing compared to our peers. And the key thing is that, you know, often when we hear the key feature being data, there's a lot of folks out there that might say, well, geez, we already have a lot of data. We collect a lot of information on all types of things in hospitals every day. And so why is this different? Well, it actually is fundamentally different type of data in that it's collected prospectively in time for the purpose of quality improvement. This is very different than administrative data that tends to be retrospective in nature and not specifically collected for quality purposes. So other features are that it is audited, it has standardized definitions, it follows patients beyond hospital discharge, and actually we're now learning that about 50% of surgical complications actually happen after patients leave hospital, so that's very important. And it does have a very comprehensive list of what a complication means. So those, again, those are the standardized definitions. So what that means is really everyone participating in the program is speaking the same language. And when people are speaking the same language, it becomes possible to start making some meaningful comparisons. And how that is done with NSQIP is that participating hospitals pool their outcomes data together so that you can take different patients from different hospitals having different operations, put those outcomes into a statistical model and account for patient complexity and complexity of procedures, and then come up with a meaningful site-level quality metric. And on the right side of the screen here, you'll see a little bar, and that's an observed to expected ratio, and that's the type of information you can get back after modeling the data in a risk-adjusted manner. So in this, what we're basically doing here in NSQIP is taking a whole bunch of apples and oranges and making them more meaningful, sort of, so to speak, making them apples and apples types of comparisons. So it's actually very powerful. And once you can make meaningful comparisons, you can actually benchmark. And this is a really important part of NSQIP. It's feeding the data back to hospitals so that they can understand how they're doing relative to their peers. So this here is a caterpillar plot. And if you can imagine, every dot on the screen here would represent a single hospital participating in NSQIP, and this could be any given outcome that's collected. So, for example, this may represent mortality after a given procedure type. And so in a snapshot, each hospital would be able to see how they're doing. So these are observed to expected ratios. One means you're as expected. If you're below that bar, over on, I'm just going to try the pointer here, over on this side of the screen, you're actually doing better than expected. So this hospital's playing birdie golf, so to speak. And this hospital over here would be playing bogey golf. So this hospital is not doing as well as expected given the patients that they're operating on. And really, when hospitals get that kind of information, and specifically providers in hospitals are able to get that kind of information, you're able to actually potentially drive some change there. So once you know how you're doing, it's a continuous cycle of collecting data, benchmarking it, feeding it back to providers, and then really the special sauce of NSQIP is getting providers to act on that data. So it's not enough to know you have a problem. The whole system relies on hospitals acting on those areas for improvement. And then if you do implement a change through a QI intervention, then it's a continuous process of data collection, and then you'll be able to understand whether or not that change has resulted in any kind of difference in outcome. So it's an ongoing process, and it turns out that this system actually works very well. So this is just a paper published almost 6 years ago now, describing the initial experience of the NSQIP system in the private sector hospitals in the United States. So this is back 2005, 2007, and that cycle of data collection, feedback to providers, and them acting on the data actually resulted in a 2/3 reduction in surgical mortality, as well as about an 80% reduction in, 2/3 of hospitals realized a change in mortality, and about 80% of hospitals improved their outcomes in some way. So there were some significant positive changes, and the interesting thing was that it wasn't just good hospitals or bad hospitals improving, it was all hospitals had the opportunity to improve, even the high functioning ones. So if you take these types of numbers and put them onto an estimate, you can sort of guess, and then the ACS-NSQIP would say you could actually prevent 250 to 500 complications per year for the average large hospital participating in NSQIP, and that may even translate into anywhere from 12 to 3 dozen deaths per year avoided. So those are pretty impressive numbers, and certainly got the attention of a lot of folks. And interestingly, just last month, there was actually an 8-year analysis put out of hospitals participating in NSQIP over a long period of time from 2006 to 2013. This looked at 515 hospitals participating in the program and almost 3 million different surgical procedures. And the results were actually quite positive if you look at the temporal trends. So basically the punchline of this was that participation in NSQIP was associated with reductions in adverse events after surgery over the time frame that the centers were enrolled. And the great part about it was that the magnitude of the QI gains increased with time enrolled. So the hospitals who have been using it for longer tend to realize more benefit. And those rough estimates that were put forward back in the initial experience actually seem to be holding now after 5 years later. So this paper conservatively estimates that the average large hospital may be able to avoid 14 deaths and about 300 complications, within those about 132 surgical site infections. So some pretty powerful data there, arguing that it's a recipe for success. And speaking of success, we'll now transition into the experience in British Columbia. And Lila is going to be speaking to you about the excellent work that they have done on the West Coast, and they certainly have a great deal of experience using the program, and I'll hand it over to Lila now.
Excellent. Thank you very much, Tim. I appreciate the introduction and the introduction to NSQIP as a whole. Your synopsis was really great there, talking about the importance of the data and why the NSQIP data in particular is especially useful to hospitals seeking to improve quality in their surgical programs. So as Tim mentioned, I am going to be speaking about the BC experience, specifically about the Fraser Health experience. So I work at Langley Memorial Hospital, which is a smaller community hospital in a health authority, and we are the largest health authority within British Columbia, and we also are the largest user of NSQIP within British Columbia. So we have 11 hospitals enrolled, and we have 24 hospitals enrolled in British Columbia. So that is the context from which I will be speaking. So why did we invest in NSQIP here in BC? And as Tim has already touched on, NSQIP is a measurement program that allows hospitals to accurately assess complication rates. It is a program that uses risk adjustment, which is the hallmark of NSQIP, and it permits side-by-side comparison of all the hospitals enrolled. So as Tim already mentioned, comparing apples to apples, so taking into account the acuity of the patients that you are operating on at each site, and taking into account their comorbidities, and still giving you a comparable benchmark towards other hospitals. Majority of the hospitals within British Columbia, the 24, they started within the spring, summer of 2011, although we did have a couple of sites that started much earlier than that, back in 2006, 2007, two of the larger hospitals here within Fraser Health. And many of our sites received their first risk-adjusted report here in July of 2012. And after you receive your first risk-adjusted report, and sometimes even before, you are assembling a team trying to get ready to act on that data. The data, of course, as anybody will say, is wonderful, but unless you're going to do something about it, it's not overly helpful. So here's just a bit of a geographical look at the NSQIP sites within BC. So there are 24. Predominantly in the Lower Mainland, although we do have sites on Vancouver Island, as well as up in the interior. We have one up in Prince George, and a couple within Interior Health for Penticton, and Kamloops. And where I'm going to be speaking from is Fraser Health, which is located mostly in the Lower Mainland, and there's our 11 hospitals highlighted there. So BC in the beginning, as I mentioned, we started in 2011-2012. We expanded from 2 hospitals all the way up to 24 within a very short period of time. So as you can imagine, the expansion was very exciting and very fast, and so that also brought some challenges with it. So that first 12 months of expansion, we really focused on getting everybody trained, getting everybody speaking the same language, getting everybody up to speed on how to interpret the data and use the data, and work within their teams and get their teams established. And so when we have the BCPSQC, or and the Surgical Quality Action Network, so the BC Patient Safety and Quality Council and the Surgical Quality Action Network were sponsors of the NSQIP program in the first 2 years in BC, and they continue to be sponsors in terms of support as well as champions for the program throughout the province and within the health authorities. So they supported the health authorities and the individual sites by doing some site visits. They ran some workshops for the surgical clinical reviewers to help get us up to snuff on the CPT codes, interpreting operative reports, and training of the surgical clinical reviewers. There was also some province-wide WebEx sessions, very much like the one we're doing right now, where, as I showed you on the previous slide, we're quite geographically separated, so sometimes in-person meetings were not possible, so the WebExes were an excellent way for us to be able to collaborate, ask questions, and be able to ensure that we were all on the same page. We also established surgeon champions at all of the sites, and most health authorities, that is a paid position, so the most health authorities are paying their surgeon champions $10,000, and that definitely helps to recruit good people. So Fraser Health in the beginning, again, I mentioned that we had 2 hospitals start in Fraser Health in 2006-2007, our Royal Columbian and Surrey Memorial Hospital. So we expanded very rapidly from 2 to 11 hospitals. In the first 12 months for us, it was mostly hiring, logistics, things, physical setup of new offices, physical setup of new sites, training new staff, and standardization of workflow. Going from 2 hospitals all the way to 11, it was very difficult to anticipate the space needs that we would have or that we would require, equipment, computers. It was quite the setup, that's for sure. Recruitment of surgeon champions was a bit of a challenge to start with. Some sites had people readily stepping forward, and other sites we had to really encourage some leadership. And getting the word out. For the first little while, NSQIP, I've heard many iterations of that acronym, NSQIP with a U. So, just getting people to understand what our program was about and what we were here to do. And it was very challenging to start with. And then, of course, because we're a health authority within a large province, it's sort of sometimes we wondered, are other people experiencing the exact same challenges that we're having? And just to expand a little bit on some of our challenges, so our site setup, hiring of new staff. So, we had to create some job descriptions and some qualifications. Obviously, surgical experience and surgical background is very important, especially when you're doing very detailed analysis of operative reports. Physical office space, you would think that wouldn't be too challenging, or at least I didn't when I first started, and it became quite a challenge to set that up and to actually get some office space within each of the hospitals. And then equipment, that was an interesting challenge for us. It's we work with double monitors and 3 computers in an office, and it was taking upwards of 2 months to set up each office, just getting the computers, as well as certain computer programs that don't come standard. I'm sure some of you guys may have experience with trying to request something from an IT department, and there can be delays with that. Training new staff, so expanding from 2 sites to 11 sites, we really had to tap into the expertise that already existed to try to get our new staff trained. It's a very intensive training program. As Tim mentioned, there's definitions. It's very rigorous, very standardized, and so the training is very intense. And while NSQIP does offer you some training, they train you on the definitions, not really necessarily on the workflow and the processes that are involved in collecting the data. They trust you to go out and seek that knowledge yourself. And so we really had to tap into our expertise within our own health authority, as well as within the province, to get our staff trained in an appropriate fashion. Standardization of workflow is interesting as well. Even though we're all working in the same health authority, we all found that we were doing our work differently. So that was one of our first tasks, is trying to standardize how we do our work so that we really can truly collect our data in an efficient way and make sure that we are able to compare our data and apples to apples. So as I mentioned, we were wondering, are we having the exact same challenges as other sites? And so what we did is we formed what we called the BC Working Group, and this was, we had representatives from each of the health authorities come together in a group. This was facilitated by BCPSQC to help us connect with each other so that we can could have some discussion, and again, on a broader level, make sure that we're collecting our data in a similar fashion. So while other health authorities, we don't all share the same, say, electronic medical record or have access to the same, some sites are electronic charting versus paper charting, we were still able to connect with other health authorities through this BC working group and help to standardize our work processes. So we formed a group in 2012 when we had one rep from each health authority, as I mentioned. We developed an interprovincial network which helped our cross-hospital and cross-health authority collaboration, and that was really amazing because, you know, a lot of times as a small community hospital, I would have patients that would end up downtown in Vancouver, and I don't have access to that information. So even just developing those relationships to follow up on those patients was really excellent and invaluable. We also, as the working group, hosted WebEx sessions, training, so hot topics, things that were being frequently asked, things that were posing challenges in each of the health authorities, and we often found the answers or ideas to help solve our own problems within our health authorities within our province, and so that collaboration was really invaluable. We also have some in-person meetings once a year. SQUAN does put on a surgical quality meeting, and we definitely have just a NSQIP session where we, as a working group, would put on a case study, a very difficult case study for the SCRs to extract before they showed up, and then we would sit around and discuss it and go over the answers and the variables. It always generated a lot of great discussion and, again, just ongoing learning, which was really important for us. Just what's in front of you right now is a timeline of what was happening in BC, and so you can see that we started around March 2011. In November of 2012, as I mentioned earlier, you don't get your first semi-annual report, or most sites didn't get their first semi-annual report till mid-2012. But in November 2011, that's a long time to wait for to start action, right? You really want to be starting action and acting on your raw data, but as new sites, a lot of us didn't really understand how to do that, and so SQUAN put the challenge out to start acting on our raw data to work on our urinary tract infection rates. So that challenge was issued in November 2011, and all of the sites by January 2012, at any of the sites that wanted to participate in that challenge were asked to submit a a goal to SQUAN and to start working on that outcome. Some other initiatives that are continuing to go on, so you can see first STAR was in 2012. There was a benefit analysis done by the province about bed days avoided, and then you can see again we're starting to see some UTI improvements, which I'll show in upcoming slide here. And currently what we're working on in BC is surgical site infection, which continues to be an ongoing issue for us, and ERAS, the enhanced recovery after surgery, as well as culture. So those are the big three areas that we're really focusing on in British Columbia at this time. Urinary tract infections, as I mentioned, that call to action in November of 2011 to January of 2012. And you can see here that there has been quite a dramatic improvement in our provincial UTI rates. So we went from a urinary tract infection rates of 3% before April 2012 down to 2.25% in 2013. They've also dropped from a combined average of 39 events per month down to 31.5 events per month in just a very short period of time. So, you know, that call to action really spurred people to understand that we can act on the raw data, and while the risk-adjusted data helps really support the work that we're doing, that we don't need to wait. And so I would really encourage any sites that are on the call right now who are either thinking of joining the NSQIP program or who are very new to the NSQIP program, you know, you have a few months of raw data and you can really start making some changes immediately. Some costs saved of urinary tract infections or costs avoided. So there's some estimations of costs associated with UTIs within the literature, anywhere that ranges very widely from $1,000 to $12,000. So a conservative estimate, just based on that that very wide range of the cost saved over the 12 hospitals that participated in the SQIP-ON challenge for reducing urinary tract infections, was $100,000 to $200,000. So it's a fairly significant chunk of change, and UTI is actually a relatively simple problem to change. There's a lot of best practices that surprisingly don't get followed within hospitals, or things that people think that they're doing well, but maybe aren't when the spotlight is shined. So it is a relatively simple problem, fairly straightforward, but it does have a smaller cost benefit. But you can see immediate results with that for sure. Speaking specifically about my site, Langley Memorial Hospital, we started as a high outlier needs improvement situation here. So we were in the 9th decile, which means that 80% of all NSQIP hospitals were performing better than us with urinary tract infections. But you can see steadily, so from January 2011 to December 2011, we really started improving our outcomes quite dramatically, and our raw rate went down from 3.4% down to 1.7%. So we almost experienced a 50% reduction in our urinary tract infection rates. We have had a little bit of a rebound in the last semi-annual report, as you can see here, but just looking at our raw data, I'm very confident that we are going to be at our best at the very next semi-annual report. Speaking of the costs of the NSQIP per site, so obviously the program is not free, and there is a cost associated on a yearly or an annual basis, and so this table here breaks down the costs of those. So on the first year, you have your NSQIP subscription or NSQIP license, you have your surgeon champion that you're paying, you have your surgical clinical reviewers, which are typically RNs, and you can have 1 to 2. QI support at our health authority wasn't established right away, and we also didn't have a clerk established right away. So our costs in our health authority for the first year was a range of $150,000 to $275,000. Year 2 onward, we added in the cost of the half-time QI support and the half-time FTE for the clerk support, and the costs are as you see there. And there is a little note down here at the bottom. If a site is a tertiary facility, so has some more complex or acute patients, their chart extraction may be a bit more difficult, and so they may need to have more clinical reviewers at those sites. Langley Memorial Hospital, as I mentioned, our urinary tract infection rates. We have done some work on cost avoidance here at our site, and we are in the process of publishing this information. But you can see our urinary tract infection rate, 3.3% down to 1.7%, pneumonia from 1.5 down to 1.2, and we actually hadn't done any concerted work on that. We've done a little bit, but nothing really a big push. And superficial incisional SSIs from 2.2 to 1.5. Organ space SSIs down from 1.10 down to 0.7. Looking specifically at a cost avoidance with a cost avoidance lens for those pieces, these are very conservative estimates. They tend to be on the low side of the literature, but this was what our findings were here in Fraser Health. And then even taking into account our program, which again, as you saw from the previous slide, it is a significant investment, but even taking that into account, we still end up with a cost avoidance of almost $550,000 over the lifetime of the program here at Langley Memorial Hospital. And as I mentioned, we are a small community center. We do about 6,000 surgeries a year here at my site. The big opportunity here in BC, as I mentioned earlier, surgical site infection. It is the most frequently flagged area that needs improvement. The issue with them is that they are multifactorial. There are multiple reasons why a site could be needing improvement in that area, and it does take, in our experience, a lot longer to reduce this adverse event. So ingredients for success. So I talked a lot about the challenges, but we have overcome a lot of those challenges, and here's some of the ingredients for overcoming these challenges. So we have some effective leadership. So surgeon champions especially, having some really engaged surgeon champions and engaged physicians in general is very helpful, as well as engaged leadership, directors, managers, people who believe in the program and who are willing to support the efforts that you're undertaking. Our local surgical quality councils reviewing our data, so we meet on a biannual basis, and the physicians attend, and we sit down and we talk about our current outcomes and what we're going to be doing about these issues. Our non-risk adjusted results, as I talked about earlier, very important to act upon those. Our risk adjusted data really does support what our non-risk adjusted information says, but we find that we can be very responsive to, even if our non-risk adjusted rates are on the rise for 2 months, we can very quickly get on top of that and identify if there's anything that we need to adjust or tweak within our process. As I mentioned earlier, paid physician champions. It is a lot of work. It is for the surgeon champions, and it is easier to recruit people if the physicians are paid, and hands-on physicians, so people who actually believe in the program. Strong surgical clinical reviewer. Data analysis is very important, as well as change management skills. So myself, while we do have some QI support here in Fraser Health, it's 2 QI people for 11 sites, and so we do need our surgical clinical reviewers to be out on the units, to be working with the staff, and to be able to help with our projects and direct the staff as needed. Multidisciplinary teams, so our teams here at Langley Hospital include everybody up from the cleaning staff all the way to our directors. So we're very multidisciplinary: physiotherapy, occupational therapy, dietitian. We have everybody around the table that could potentially impact any of our outcomes. And quality improvement support is essential. So I mentioned we have 2 people for 11 sites, and that is the quality improvement specialists. They're the people who are most versed in our change methods and are able to provide a more structured approach for us. So lessons learned, it takes time to set up an NSQIP site. People are raring to go. They want the data. They want, it's amazing, the thirst for the data when you first start. It's hard to tell people that they need to wait because you really do need to have a good footing before you're able to, present your data in a sure way. So you don't want to be presenting something that could change. It's very difficult to get to develop trust especially with physicians, if the information that you're giving out changes all the time. So it does take time to set up, and patience is very challenging. Engagement at all levels accelerates change. So if you maybe have great nursing engagement and poor leadership engagement, it's going to be really difficult to get the change initiatives off the ground. And if they do get off the ground, it's going to be very difficult to sustain them. The semi-annual reports, those are the risk-adjusted data, they motivate people. You show those up and you show a group of physicians or a group of nurses, and I think Tim mentioned this earlier, areas where they're doing poorly. Nobody likes to see that. Nobody comes to work to harm our patients every day, so they definitely motivate change. Acting on this non-risk-adjusted data, I've already spoken about that, and collaboration and idea sharing can provide a new insight to an old problem, as I mentioned, within our working group. It was invaluable to have the collaboration with other health authorities and other SCRs. So this is Dr. Doug Cochran. He is the physician lead in the BC Patient Safety and Quality Council for the SQUAN network, and this is a quote from him saying, that NSQIP has confirmed that unless there's a clinical leadership and a culture for change, the program will fail. It's the action that makes NSQIP worth it. So again, speaking about the data, it's great that we have data, but unless you're going to act on it, it's just numbers on a piece of paper. And that is my presentation, so thank you very much again for the opportunity to speak. And I've put both my contact information in Kimberley McKinley, who works for the BC Patient Safety and Quality Council, and she is our surgical contact there. So if you have any questions, please feel free to contact either of us. And I'll now hand it back over to Tim. Thank you very much.
All right, thanks so much, Lila. That was fantastic and really inspiring work that you guys are doing in BC. And to be honest, a lot of what you've done has enabled us to increase the number of hospitals and get our program through HQO up and running. So thanks for that. So what I want to do is just refocus back to Ontario for a sec. And I wanted to just give you some of the early experience that we've had with NSQIP at my hospital. So just to give you another sense of how this works. So this is a actual risk-adjusted report that I got back in 2012 at my site. And you can see here with the purple bar, we're a high outlier for this outcome. And this happened to be a surgical site infection after a specific type of surgery that I do a lot of, weight loss surgery. And it told us that we had a problem in wound infection after that procedure. So that was something I had no idea about until this data showed us. We were able to actually talk to other centers participating in NSQIP that had the same issue, and we made a few small changes with what we do in the operating room and actually some of the equipment that we use to access the abdomen during this surgery. And we were able to see a reduction in the not only the rate of surgical site infection after this procedure, so you can see from over the 3 quarters that I've outlined here, we actually dropped from the 9th decile being a high outlier down to the 8th and now down to the 5th, and we've actually been able to sustain that. But also our actual overall complication rate had tended to drop by looking at the data as well. So we had some early wins with some high outliers, but I think what Lila was saying pretty clearly too is that it's much more than just data. So while this may represent some low-hanging fruit, we really have to think about these things a little bit more carefully. So there was a good reality check, which actually was published last month in JAMA, actually 2 months ago in JAMA, which basically looked at the experience of all NSQIP hospitals participating in the United States. And they looked at hospitals that were participating and compared it to those who were not. So the way they did this was look at large administrative claims data sets, specifically the University Health Consortium and Medicare. And basically what they found was that while there were high performers and low performers within the NSQIP hospitals and the non-NSQIP hospitals, the participation in NSQIP alone didn't necessarily translate into improved outcomes. So this was a very clear message that, as we've been saying, data alone is not enough. It's much more than that. And so one thing just to sort of take stock of where we're at, NSQIP has most certainly been able to give us good information about our performance through getting high quality data, the risk adjustment, and sort of have a meaningful information to providers and hospitals. But the challenge now is really getting that information and translating it into improvement. And I think that's really what Doug Cochran was getting at in his quote, is that it's not just knowing how you're doing, it's moving the needle and acting on that. So what do we actually need to do? Well, we need to work together, and that's what BC has demonstrated very well, and also we need support. And so you heard a great example of that in British Columbia. I wanted to provide you with a couple of other examples of how when hospitals work together in a collaborative manner, it actually accelerates the QI process around NSQIP. So Michigan's a great example of that. They have 66 hospitals enrolled actually back since 2005, and they've been able to reduce complications significantly and actually translate into a huge cost savings in the range of tens of millions of dollars, so much so that their insurance companies have actually decided to pick up the cost and support the quality program. So pretty powerful data out of Michigan. Similarly, in Tennessee and Florida, groups of hospitals recently have gotten together. They've decided to benchmark across each other, identify some common quality improvement targets, and have realized some actual improvements in many different areas, and have actually published on some significant associated cost savings. So these papers are up for your review as well. So similar to British Columbia, these regional collaboratives have actually done similar things, and seems to be a good way to do this. So adding in that extra support, not just the data. So what we're trying to do in Ontario with Health Quality Ontario is get hospitals together as part of an ACS-NSQIP collaborative, and really learn better on how to not only increase the number of hospitals participating and surgeons getting their data, but really how to identify best the opportunities to support that quality improvement within these hospitals, and really develop a community of practice around NSQIP, and really focus on making those changes, moving that information to improvement. So it's been quite a remarkable process. We actually just put out a call for expressions of interest in just late last year, and we were hoping to have about 15 hospitals interested. We actually had almost 50 hospitals applying for funding. We actually were able to get 19 hospitals as part of this program. We have a great mix of academic teaching hospitals, community hospitals, and actually some quite remote and rural hospitals. And they're actually listed here. So Very diverse geography across the province, representing again all different types and sizes of hospitals, and we're actually sampling surgery not just in one type of surgery, but in most specialties across these hospitals. All hospitals are actually participating in NSQIP with regard to abdominal surgery or general surgery, and we've actually already these hospitals have just enrolled in the last month or so, and we've already had several surgeon champion calls, and I believe we have a great group of not only surgeon champions who are truly interested in the program, but also surgical clinical reviewers, which have really bonded together. So it's amazing that in just a month or two, we've had, we went from 4 hospitals to 19 hospitals enrolled, and pretty much establishing this network. So the key point that Lila was getting across as well, that I've been trying to get across, is that it's not just the data, it's a lot more than that. So one thing we're hoping to do with Health Quality Ontario is really focus on building that community of practice. So yes, we have the data, and that's going to be supplied with the NSQIP program, but we also want to supply and make readily available the evidence and the best practices and really support those QI interventions at the hospital level. And I think that's a key element of success. And the other key component is the oversight and governance of the whole program. So really, yes, it's being run through HQO and as a primary stakeholder, but really it's a partnership between the member hospitals. And this really is going to empower the providers to look at their own data and help set the QI agenda. And I think that that's going to be a real key component of this as well, is sort of letting the surgeon champions through a hospital leads group help determine what quality targets we want to work on as a group and really help strengthen that community of practice. I want to show you just briefly, we have a great website set up already to represent the network, and all the NSQIP Ontario programs have access to that. And what we hope to do in there is really 2 things: not only provide the QI support, which I've been mentioning, and the resources, but also to provide some training and resources in terms of how to actually influence change in a hospital. So we are providing some curriculums for the surgeon champions and the participating hospitals about how do you actually approach QI in a hospital. And one of the early messages I've been getting from the surgeon champions involved is that, you know what, we really don't speak the language of QI and we need help with that. So right before we're getting data, we're actually working on getting the surgeon champions and the SCRs up to speed on how to influence change, plus partnering with other organizations who have a lot to offer in terms of best practices and evidence. So that's just a snapshot of what we're hoping to do at HQO and for NSQIP Ontario program. And I think to summarize both of our presentations, I mean, I think it's fair to say surgical quality is most definitely measurable these days, and it's something we should be doing, and I really think we have to be doing for our patients. That the whole concept of data-driven quality improvement is a good one, and that it can actually move the needle, and that collaboration accelerates the process with the right QI support. I always call it a triple win. So patients can have the opportunity to have fewer complications. As providers, we can improve care for our patients, and as a side effect, we may be able to reduce cost through using these programs. And I think that one of the key learnings over the past 5 to 10 years has been that really when it takes hospitals working together with the appropriate support to actually go from data to change. And I hope that's what we'll be able to do in Ontario, and that's certainly what BC's been able to do in a very impressive fashion. So that will just conclude our presentation. I'm certainly more than happy to take any questions. I guess we'll turn it back to Stephen.
That's great. Thank you very much to both of you. That was a terrific couple of presentations and gave us a real sense of both how NSQIP works, but also some of the real advantages that we're beginning to see through the program at work in both BC and Ontario. I'm going to jump right to questions now. I have one from Roberta at Alberta Health Services, which says, is follow-up on improvements made at the local level driven by NSQIP or through reporting by the local hospital making the improvement? Is information about local improvement initiatives shared immediately? Maybe Lila, do you want to talk about that in BC?
Yeah, I was just reading that question through. So definitely when we first identify an area where we're having difficulty, so for example urinary tract infections, we look at our best practices and go ahead and look at the ones maybe that we're not doing yet. So we use a variety of QI methodologies across BC, across a health authority, and so really depending on which one is going to be working at your site. So for example, at my site we did a TRIZ, we looked at all the things that we weren't doing to help prevent urinary tract infections, and we went ahead and tried to start making some changes to that. Once those are implemented, we evaluate those through looking at our raw data, through looking at our SAR, and then we continue to report out on those and look at our ability to sustain those, continue to audit those practice changes, try to evaluate whether or not we've made a difference, whether we've made an improvement, and we look at that statistically as well. So, we don't just go, great, it went down 1 month. We're looking for a sustained result here. So I'm not, I hope that, and then of course we do some collaboration across our health authorities. So, if we're not the only site that has an issue with urinary tract infection, there's lots of hospitals across the health authority and across our province that have that same issue. So yeah, absolutely, and part of our collaboration is within our own health authority through staff meetings, through working with other hospitals closely, and through the province, through both SQIP-ON and through our BC working group. We collaborate that way as well to spread the change so that other people aren't reinventing the wheel. And I hope that answers your question.
Great, thank you very much. And we'll also stay with you, Lila, for this question from Carolyn at Nova Scotia Health Authority, wondering if BC would be willing to share the workflows that you've developed to possibly help jumpstart others.
Yeah, I absolutely think so, Carolyn. I think the best person to contact for that would definitely be Kimberley McKinley. She has a much more broad perspective than I do. My perspective is quite, while I was the chair of the BC Working Group, Kimberley has a very good overview of all the health authorities, because as I did mention, we do have different, there are different pieces to each process. There'll be pieces that are very similar, but there'll also be pieces that are different based on our computer programs, things like that. So absolutely, we are more than happy to share, because we believe this is an amazing program, and anything we can do to help other people get the benefit from it, we're on board with.
That's great. Thank you so much. That's wonderful Pan-Canadian collaboration at work here. We have another question from Lisa Kallstrom in BC. Have you addressed the prevention of acute pain from transitioning to chronic pain as a complication after surgery? Either of you would like to speak to that?
To be honest, I was looking at that question. I'm not quite sure how to answer it. I think we're looking at trying to reduce the impact of acute pain around surgery with programs like Enhanced Recovery. So there's a lot of multimodal ways that we try to actually reduce that initial hit. Now, anything specific to reducing transition to chronic pain, I'm certainly not aware of with regard to NSQIP. Maybe Lila can comment on that more, but I think ERAS is where we're at now.
Yeah, I would agree with you there, Tim. Specifically, pain as an outcome from a NSQIP perspective is not one that we are capturing. That being said, I think, prevention of complications as a whole can have an impact on that. And as Tim mentioned, the ERAS program is focusing on pain control specifically to help reduce complications and help people get home faster with less issues.
Great, thank you. Again, from Carolyn at Nova Scotia Health Authority, is there any duplicate data collection done through either NSQIP or CIHI?
Yeah, I could comment on that. So there most certainly is. I mean, basic surgical outcomes are collected in both NSQIP and CIHI. So things like, readmission rates, some types of infections and what have you. So there is some redundancy in data collection. I think that the data in NSQIP is actually quite different than the CIHI data. So there are different definitions. But basically, from my perspective, there is a duplication in data collection, and part of the challenge moving forward is how do we reduce that redundancy and leverage the best out of our quality data and our administrative data? How do we link the two? And in fact, you can link NSQIP data to CIHI data. It is possible. We have done it, so hopefully we'll get in a sense where we'll get to a point in time where actually our electronic medical records can help inform these databases as well. So a lot of work to be done there.
Great, thank you, Tim. Another one, this one again for you, Dr. Jackson. It's from Maurizio at Vitalité in New Brunswick. How do you manage to overcome the challenge of SSI detection once patients are discharged?
Yeah, so one of the great things about NSQIP is the follow-up after the patient leaves the hospital. So, the patient may have been seen in a surgical clinic at 4 weeks or so. It's 30-day follow-up, and we may know what happened to them, but we may actually have to contact the patient, and there is a strict definition for SSI that we go through, and we ask the patient, these questions if there haven't been followed up. So, I think it's actually pretty good at detecting SSIs, and if we're not sure, we actually talk to the individual. My own personal feeling is that we tend to underreport SSIs because the definition is actually pretty strict. But we are able to get a good sense as was there a problem with the wound or not, and we'll go from there.
Thank you. And this question is also from Maurizio, this time for you, Lila. What is the profile and the exact role of the surgical clinical reviewers?
I think I like to consider myself a jack of all trades, to be quite honest. We have to. So our surgical clinical reviewers are definitely responsible for the data collection. So we're responsible for the selection of our cases, for identifying which patients will be reviewed, for extracting the data from the charts, to following up with the patients and overseeing that whole process. So we may have clerks or other staff doing different pieces of that process, but it is our job to oversee that process. It's also my job to ensure that that our data doesn't just sit on a piece of paper or on a PowerPoint slide when it comes to us from NSQIP. So my job is to also interact with my surgeon champion. We have regular meetings. We discuss our quality improvement initiatives, areas that we want to focus on, and we develop a game plan. What are we going to do with that? My job also includes liaising with our QI people, liaising with our frontline staff, leading those action teams, identifying the right people who need to be around the table and organizing some of that. Data analysis is definitely in there, and I think I shouldn't underrepresent that at all because the analysis that's required is quite intense, and you do get a lot better at it as time goes on. So if there's any SCRs on the call that are just starting that don't have a data background, don't despair, please. You will get better at it. It's an acquired skill for sure. Even liaising with people outside of your health authority. So NSQIP, while it's a surgical quality program, it does have impacts in other areas of your hospital. So it does help if you can develop relationships with other areas. For example, right now in one of our urinary tract infection initiatives, we're working with our emergency department as well as our critical care area. So bridging that is also I consider part of my job, and even having meetings and contact with our directors and our executive directors all the way up to, our CEO reporting out. So, our job description is quite broad, but you can make it as narrow as you want. I mean, I think I tend to be I am a leader within my health authority, so I think my job description is a little bit broader than others, but, I would say that that's a pretty accurate representation of what a lot of us do.
Thank you very much, Lila. That's great. I just want to let you know, MJ in Nova Scotia and everybody on the line, that the slides that you saw today are available now on our website, and that the recording for the call from today will be available on our website by the end of the week. Before we end the call, I'd just like to also invite all the participants on today's call to take note of our next upcoming webinar taking place on May 8th. This webinar is the second part of a four-part series on moving from usual care to chronic care, featuring Dr. Ed Wagner from the McCall Center for Healthcare Innovation in Seattle. This webinar will focus on the evolution of the care model and the movement toward designing care with chronic as the new norm. And the remaining two sessions for this series wrap up in June. On the slide here, you'll be able to see a full list of the upcoming webinar sessions taking place between now and June. At this time, as we end our call, I'd like to thank very much Dr. Tim Jackson and Lila Gottenbos for their excellent presentations today, and also for Sheena and Kelly for working behind the scenes here in Ottawa. If you could please take a moment as you sign off today to fill out our webinar survey using the link that will appear on your screen in a few moments, that would be greatly appreciated. I'd like to thank all of you for attending this session and for today's call, and particularly to our two presenters. Thank you for an excellent presentation, both.
Thanks, everyone.
Thank you very much.
With that, we'll sign off. Thanks very much, everybody.
Thank you. Ladies and gentlemen, this does conclude your webinar for today. We thank you for your participation.